Thank you for having me. Like you said, I'm Megan Lagosky. I'm our BPD director at Lurie Children's Hospital in Chicago. It's a pleasure to be lecturing to so many people today. For today, we're going to be talking about ventilator management and severe BPD. You could talk about BPD forever. In fact, there are conferences on it. So to just speak on the topic of BPD would be a disservice to it. And so today, I'm just going to focus on the patients who have the most severe BPD. So if there are questions during the presentation, then please stop me. Otherwise, I'll get going. So this is actually a lecture I've given our fellows almost every year. And I think the topic, I hope that no one's offended by it, but it's so different than the ventilatory strategies that we use in respiratory distress syndrome. And I just will talk a little bit about why during this. If I can, all right. So just a reminder, you can read the screen. All right, so my objectives for this are to explain the evolution of BPD over time to help us kind of evaluate the evidence that's out there. And then we're going to go on to reviewing ventilator strategies. So, and that's actually even just going as basic as how do we breathe, and then differences in respiratory pathophysiology and BPD, and then selecting ventilator settings. And then I wanted to talk a little bit about detecting patient asynchrony with the ventilator, because I think it's something that's really difficult to find, but the problems that come with it can be incredibly important. Then I'll leave time at the end for a question and answer. So this is the neonatology exam content. Can you guys see that? I know that there is things flashing across my screen as people keep coming into the room. So it looks okay, right? All right, so this is actually, there's one topic that's specifically chronic lung disease and bronchopulmonary dysplasia. So we are going to talk about some of these things. I think it's funny to know the management of bronchopulmonary dysplasia, chronic lung disease, because that's actually simplifying it a lot. And I'm not sure that we have a lot of high quality evidence that shows that we absolutely know exactly what we're doing, but we know that survival has improved. And then looking at long-term complications. I'm not going to get into that too much today, but it is a really interesting topic. And really the patients who are living now who have BPD are in their 40s. So we will learn more as time progresses. Then this is the rest of the respiratory section. And actually, we are going to talk a lot about this specifically within the context of BPD, because you actually do need to go back to your anatomy and physiologic dead space and all of that kind of stuff that you may be traumatically flashing back to right now when you were in medical school for this, but you have to know it for your boards. So going back in history, there's a lot of evidence on therapies for neonates, and we're actually a very lucky specialty because there is a huge population of neonates that are born. So we have a lot of randomized control trials and high quality evidence out there. And I used to think like, oh, there's a Cochrane review on this. And so that's a meta-analysis and that must be the best that's there. So everything that's said on there is written in stone. That's what we should be doing. However, this is tricky, right? Because there is old BPD and then there's new BPD. So this is just a timeline of how things have changed a lot. And in 1967, Northway first described BPD, and it's a very different BPD than the kind that we see today, although there's a little bit of overlap. And we actually haven't been intubating babies and using ventilators for that long in the history of time anyway. We haven't been using CPAP. We haven't been giving surfactants for that long. And we haven't been giving steroids to mothers prior to preterm birth, at least down to 24 weeks or even earlier than that for that long. So really a big change happened in the 80s and 90s and even in the early 2000s. And so what you see on this picture with the lung development here is that there's 5 stages of lung development, and you do have to know all these. Basically, it's like 5, 15, 25, 35, and then beyond. But it's when all of it starts. But what you used to see is that these patients who Northway described were actually in that 34 to 36 weeks, sometimes 30 weeks at the earliest, that were in fairly solidly in the saccular stage of development, but we're seeing these patients who are in the canalicular to saccular stage of development. So it's a lot different. So management has changed. So there's a table that shows old BPD and new BPD. The average gestational age has changed a ton. And actually, if we look at it now, this new BPD is actually 22 to 26 weeks. birth weight's different by 3 times the birth weight. So infants that are, the gestational age is a lot different. The airway injury is actually severe. But I think when you go through this table, I could read it out loud to you or not, but I think we need to know that when we get to this picture all the way on the right, that there's still overlap between these two and the most severe BPD. You can see a lot of the changes that you see in old BPD and these patients who are born at 22 to 26 weeks. This is just a picture of what survival trends have been over time. And what you can see is that survival has increased, but the rates of BPD have not really decreased that much. And I think it's partially because our youngest patients who are most at risk are surviving more and more. So here is the tricky thing. BPD is a crappy diagnosis in general, but we're doing the best we can with what we have. We base our diagnosis on the support that a patient is already receiving. And if you think about any other disease process, it's not really based on what treatment you're already giving. But we base it on, we kind of can categorize it based on the risks that patients may have as far as neurodevelopment or respiratory morbidities in their first years of life. And that's actually the closest that we get to that is in the Stenson criteria that's down here where you have grades of BPD. But I think the one that's most commonly known to everybody is the one that's on the upper right corner, which is the NIH definition of BPD. Whereas if they are at 36 weeks, you break it into mild, moderate, or severe based on the amount of support that they're getting. So patients with the most severe lung disease are surviving more often. The timing of achieving a pro-growth state for them is variable. And then you're getting these patients in an unstable and transitional period, and it takes a long time for them to get better. I'm going to go into all this a little bit more later. And this is hard because really what we're doing is managing chronic disease in an acute care setting. But I honestly believe that the NICU isn't really as an acute care setting as we think it is, because we have patients that are in our hospital for months who may not actually have lung problems. So we actually are pretty well suited to manage this. And we just have to have more patience, which we do whenever we're trying to feed patients with short gut, going up on their feeds by 1 ml every 5 days, or a patient who has to adjust their feeds and is just feeding and growing, so this is a shift in mindset that needs to happen. So I am going to, hang on one second. I need to check one thing, if you don't mind. I'm going to, let me just exit out of this. Sorry. Yep. All right. So I don't know if any of you, the more I give lectures, the more I realize that I'm out of touch with people who are probably receiving the lectures, but this is from the Muppet Show. This is Beaker. So our research on therapies for BPD is actually not really, the bulk of it is not an established BPD. So anything beyond 4 weeks, there's very few studies that are large numbers of patients. Most of it's in the prevention and treatment of BPD. And the interesting thing is that since when we group these studies together, we have to remember that 97% of our patients now with BPD are less than 1,250 grams, but many of them randomized control trials that are included in meta-analyses actually these studies were conducted in the era of old BPD, and they had smaller numbers of VLBW infants. And so this is tricky when you interpret this. Diuretics is actually a really good example of this. If you look at the meta-analysis in the Cochrane Review, they actually use studies that are before 1998. And so that's before the 2001 statement for giving antenatal steroids is really around. So you have to think about that whenever you're thinking about the patients and look at the gestational ages that they're including. So we don't actually know what the effects are of diuretics, both on the patient populations that are 22 to 24 weeks, and even the 24 to 28 weeks that well. So I'm not going to talk about how to prevent BPD, but I think I just wanted to tell you that this article is a really nice summary that came out, I think, last year on interventions to prevent bronchopulmonary dysplasia. It's kind of very short summaries of all the different things that have happened over time to prevent it. We're talking about something where the ship has sailed long ago. All right, so I'm going to talk about vent strategies now, but I am going to talk about some physiology. There's a lot of differences between RDS and BPD, and you can read through all of this. When you look at RDS, the way we describe chest x-rays are very granular appearance. It's more homogeneous or homogeneous, whichever syllable or way you want to pronounce it. There's normal airway resistance. It's really common. There's rapid improvement, and it's usually uncomplicated. And this one is well studied, and the goal is to extubate. It's to get to the next lowest amount of support. BPD is a chronic condition. It's multi-compartmental, and I'm going to talk about that concept in a little bit. There's high resistance, and there's some areas of low resistance. It's less frequent, although we end up seeing these patients because they're around for a long period of time in the hospital. The improvement is really slow, and there's many comorbidities that go with it. And if you under-support these patients and go with the concept of weaning, or as one of the people that I work with has said, weaning is winning, it actually may not be, because it may take away from the other baby things that they need to do. And that can actually increase their morbidities too and cause organ stress. So this adequate support concept changes too. We measure a lot of that based on blood gases and the appearance of a baby in the acute phases of RDS, but in BPD, it's different because a normal blood gas doesn't actually equate adequate, especially if they're working really hard and can't really do anything else besides lay in bed. They can't tolerate their therapies. They can't change positions. It's hard to move them at all. And they may be desaturating constantly. So a pH of 7.3 may not be great for them, or even 7.35. Conversely, there are patients who have enough unhealthy lung that their blood gases may never be normal, at least in the NICU, and their CO2 levels may be higher, and they may be comfortable, and they may be checking every other box. Their heart may be healthy, they may be growing, they may be doing their therapies well, and that actually may indicate better support than the earlier discussion that we had. So it's really important, and we want to see if the baby looks comfortable most of the time, and that's actually, as physicians and frontline providers that are taking care of these patients, we're in the room for the least amount of time usually, unless these patients are really, really sick. So us going in there and looking at them for 5 to 10 minutes, once or twice a day, actually isn't adequate enough to define stability and adequate support. We need to know if growth is happening, and it's not just gaining weight, it's linear growth, because linear growth actually is a good reflection of organ growth, and the lungs are obviously an organ. And then we also have to look at the strain on the heart. So is there pulmonary hypertension? Because we may be causing VQ mismatch, and VQ matching is the first therapy for this. So when you're ventilating these patients, when you're supporting them with any kind of respiratory support, you have to come to terms with the static condition of severe BPD. So don't rapidly wean them. You have to provide the support needed to decrease metabolic expenditure and improve growth and energy. And remember, when these patients are over 36 weeks and beyond their due date, they're a baby and they are not incubating in a box anymore. So they should have as many normal baby interactions as possible, which is hard to do in an ICU. But they need the energy to be able to do that. And if they're focusing all their energy on breathing, they're not going to be able to tolerate therapies. The modes of ventilation need to be optimized to address their pulmonary function present in the damaged parts of the lung. So you have to ventilate the healthy and damaged parts of the lung. And then you actually really have to avoid breath stacking. There's different phenotypes of BPD. I'm only going to go into this briefly because there's discussions that go much more into this. Some patients have poor lung parenchyma, and that may be homogeneous, heterogeneous. Some of them may have airway disease, and that's like tracheomalacia, bronchomalacia, or even smaller airways disease. And some of them may be reactive, and some of them may not be reactive. So it's not as satisfying as treating in asthmatic patients. They may not have as good of a response to bronchodilators. But in small airways disease, it's hard to see, either through bronchoscopy or a CT scan or anything else. We have to just kind of pay attention and adjust their ventilator to see if we can open up those small airways and help them ventilate. And then some of them have pulmonary vascular disease predominantly, but a lot of them have a combination of all. So I'm going to go back to how do we breathe. When we breathe, and I have talked to our fellows about this before, our main driving force is the diaphragm. So the diaphragm is a muscle. When it contracts, it pulls downward. So it creates negative intrathoracic pressure. So there's a vacuum on the inside. So for all of us, that means if there's a negative pressure, it's easy for us to start to breathe in. Inspiration should finish when flow returns to 0. This is on a ventilator, and the lung is hopefully filled to the desired tidal volume. So if you see here, there is this red arrow that shows where the flow So here the flow goes up, it goes down, and then it goes back to zero. And this is where pressure equilibrates within the airways and even hopefully air spaces. Now, if you look at this, you actually can see that there's a pause before expiration happens too. And so this I time might be a little bit long for this patient on here. And then you enter exhalation where you have this negative dip, and then that should return to the baseline. In gas transport during mechanical ventilation, inspiration is a time for gas to travel from one end of the airway to the other, and it depends on your PIP, your inspiratory gas flow, and your pressure flow waveforms. In your expiration, that depends on your chest wall elastic recoil, expiratory resistance, and then your set PEEP. And it's not just your set PEEP, it's also intrinsic PEEP too, and trying to be able to overcome this. If inspirations and expirations are long enough, you should have proximal and distal airway pressures that equilibrate, and gas flow should stop. And to understand how this works, you have to actually talk about time constants. So we're kind of getting into, don't worry, I'll wake you up later whenever I talk about specific numbers. If you need to know something specific on how to manage the ventilation, I will talk to you about it. This is really, I mean, this is important for you to know in general, so you can actually reason your way through this, but it is heavy stuff. So time constant is the product of lung compliance and airway resistance, and it's measured in seconds, and it's like standard deviation. So when inspiratory time is shortened beyond 3 time constants, a pressure gradient develops between the proximal and terminal airways, and tidal volume is a function of this pressure gradient. So I'm going to show you an example of insufficient inspiratory time. The ventilator, so the way we're breathing right now, we're getting the air in that we want, and we will be able to breathe it out when we want to. We are taking over control for patients when we put in the inspiratory time and we put in the rate and everything else. And so it's actually something that we really need to pay attention to. Otherwise, there's going to be a pressure gradient and the air is not going to be delivered efficiently and effectively to the air spaces that need it. And then the other thing you have to remember is that your area resistance is always greater during expiration. So your expiratory time constants should always be longer. And expiratory time constants less than 3 don't allow for adequate lung emptying. And in our patients who have BPD, it may be closer to 5. So this is where I'm showing you how old I am. This is a picture of the Princess Bride. This is an inappropriate time constant, and it's the cliffs of insanity. And this actually, you need to know that this would be in a patient who doesn't have any kind of leak or significant leak around their endotracheal tube. But what you'll see here is this positive deflection up here to this point right here. And this is actually where inspiration stops on the ventilator. And then the patient just exhales and you reach the exhalation part. However, this is a pressure gradient right here. You can see that there's this cliffs of insanity that I call it, where you're actually delivering pressure and volume somewhere, but it's probably not getting down to the places that you need it most, and actually being able to diffuse across to the areas that also need it most. So you should increase your I time in this situation, and you really need to pay attention to this. But the thing that you also have to pay attention to is, if you look later here, this expiration returns back to 0 here. But if you increase your I time, and this is actually just us giving the rate that we prescribe, you're going to end up having some breath stacking that happens. So this is where you can have a spiral of ineffective ventilation that starts with breath stacking. So you can have no pause between the initiation of the next breath. You really have to pay attention to the ventilator on these patients here. So you can see these small arrows right here for this, picture. And it shows that the flow does not return to 0 before the next breath starts. And so what you will find in time is that these patients will continue to breath stack if we don't pay attention to that. And the solution is to go down on the rate. One thing that I worry about a lot, and I think about in these patients, and some people will tell us like, oh, you should go down the I time so we can go up on the rate. But then you end up getting these cliffs of insanity, and you actually are not delivering the tidal volume equally in healthy and unhealthy portions of the lung. So our vent strategies are based on the pathophysiology, and the clinical trials are really lacking. So time constants depend on resistance, and there's acute lung disease that's characterized by low compliance and normal resistance. Chronic lung disease is by increased resistance to airflow and air trapping. And what you can see is that our patients with BPD actually have, this is fast space, This is your slow space right here. And then really the two of them together create this. And you'll see this is actually similar to someone with COPD. And that's basically what a lot of these patients have, because if you believe that, if you see the studies that we have, which are limited, 90% of our patients have some amount of obstructive lung disease. So we have to support a multi-compartmental disease. And this is a nice picture that is taken from many of the papers by the BPD Collaborative on managing patients with severe BPD. And what you can see is that when we are trying to, quote, gently ventilate these patients and give those low tidal volumes and short inspiratory times, you are preferentially ventilating specific areas of the lung that actually are getting all of the tidal volume delivered there. So it's actually not so gentle to these areas. And what can happen over time is that some of this may end up in these areas down here that are pinched, and that they may not be able to escape. And this gets bigger and bigger, it can smush other parts. So you have all sorts of different compartments. So we say 2-compartment disease. Sometimes you'll hear it referred to as that, but it's probably 7, or more. Normal compliance, normal resistance, low compliance, high resistance, so on and so forth. When you give a higher tidal volume, higher opening pressures, longer inspiratory times, and a slow rate, you allow for gas to equilibrate better in these patients. You also have to think about dead space in these patients. You guys are going to be really excited about this lecture, I know, afterward. So dead space, to refresh your memory, if you look at this picture on the right, there's apparatus dead space. So if you have a breathing tube in, and then the tubing that goes to the ventilator, that's dead space. And that does not participate in ventilation. And then there's physiologic dead space, that's the anatomical dead space and alveolar dead space. And then there's alveolar ventilation that happens. And so these are things you have to think about. And babies with BPD have more dead space. And they have more cystic and emphysematous lungs that are poorly perfused, which then smushes the other parts of the lung, that creates some VQ mismatch too, which actually isn't part of dead space, but it really isn't an area that's actually being ventilated either. And then they also may have some acquired tracheomegaly. When those pressures aren't being delivered down to the airspace as well, it gets stuck in your proximal airways too. And there was a paper, if you look, this is a reference down here, this physiologic dead space and alveolar ventilation in ventilated infants. There was a small number of patients with BPD, but some of their dead space actually was 6 mLs per kilo. And if you think about it, that means that our 4 to 6 mLs that we give patients are 4 to 7, we're depending on where you practice. When we do volume ventilation or aim for that, would actually just be ventilating dead space. And any other ventilation might be through entropy. All right, so wake up. We're going to go to ventilator settings. So specific strategies to prevent the cycle of ineffective ventilation, you have to understand the open lung concept. And this is my cycle of ineffective ventilation. It happens. So you get these air trapping that happens, your slow time constant units don't fill, your physiologic dead space accumulates, then you have hypercapnia, then babies are upset and they breathe faster and get air hungry, and then they have worse air trapping. Your tidal volumes are completely different than what we talk about for RDS. They may be as high to 8 to 15. Some people feel that the sweet spot is 9 to 12. I times are longer, rates are much lower, and we usually avoid assist control. And then your peeps are higher. So we have patients who have peeps of 15 here. We like to not have that happen, but a lot of times it's 10 or up to 12 sometimes in patients. And the other thing that we have to think about, and this is a really hard concept, because when we talk to staff and we talk to the people that we work with, weaning is a cornerstone of respiratory management. And we feel like that is progress, but that happens so slowly in these patients, and some of them at least, that we actually just need to stop talking about weaning. We need to talk about adjusting the ventilator to fit their needs. All right, this is a picture. This is just another representation. These BPD patients have heterogeneity of lungs with fast fill and empty and slow fill and empty compartments. And these short I times preferentially ventilate the short time constant units. Again, I put this in here twice because I think it's a really important concept that is overlooked so often on the ventilator, that you really need to look at this. And one of the big questions is, when should we make these changes? And we should make these changes in patients when they need it and when they're showing us signs that their lungs are becoming more heterogeneous and we are not ventilating them appropriately. So look at the truncated flow here again. That's the cliff that I was talking about. So you need higher pressures and volumes to ventilate all of these compartments. Your PIP for this, it's really uncomfortable. It's sometimes why we actually have switched. I mean, not really, but if you put in a volume ventilation, you may not be thinking about how much pressure you're requiring, but some of these patients need PIPs of 50 to be able to ventilate well. Sometimes they need it a little bit higher. But remember, we think about volutrauma and barotrauma, but we have to think about also providing stability for these patients. And I think that like we said before, when we were talking about preventing BPD, that ship has sailed, and the amount of pressure isn't as important as the amount of volume delivery. And then the question is, how do I set pressure support in these patients? Because and I'm going to go back to what mode we use in patients in a little bit. And that's a great question. And I don't know if I have the exact right answer. I think it's really center specific too. Some people say your pressure support should be about 60% at least of what support you're giving in your vent breaths that are either pressure control or volume targeted. But the goal is to provide some support for comfort. But if we provide a huge amount of support close to AC, then we may actually end up having some breath stacking that happens. And so they should provide, so sometimes pressure support breaths can be 12 to 16, and that's the delta P, remember, because depending on what ventilator your center uses, this may be the number that you see, maybe the total, the number, usually with pressure support is the delta P. It should be enough, although some patients may need a little bit higher. All right, so we're going to go to PEEP now. And these are, I don't know why. I mean, if you love Peeps as Easter candies, they're the candies that come out around March and April, more power to you, but I think they're gross. They are really fascinating if you put them in the microwave though. But that doesn't have anything to do with babies. So there's different kinds of PEEP, right? There's the PEEP that we set on the ventilator. There's iPEEP, auto PEEP. All of these things we actually have to take into account when we're figuring out what is right for each patient. And the combination of a BPD patient's respiratory mechanics and the respiratory drive sometimes results in adequate emptying time. And so if you're breath stacking, you're going to find out that there becomes more and more intrinsic PEEP that you have to overcome. And some of these patients may just have high intrinsic PEEP anyways because of airways disease. So we should talk a little bit about hyperinflation that can happen in these patients. And that can happen from multiple different reasons. Sometimes it's just because they have the elasticity of a dollar store slinky. Like you stretch it out once and it's hard to really have it recoil back to what it was before. They may have tachypnea, and they may have ineffective eye times, inadequate recognition of when they move toward multi-compartment lung physiology, in inadequate tidal volume, leading to more tachypnea, not enough emptying time, large airways disease, small airways disease. It's super straightforward. I'm being sarcastic. I realize that a lot of the people online don't actually know me, so I should probably just tell you when I'm being serious and sarcastic. So here's something to also look at on the ventilator. This is an example of intrinsic PEEP. And this actually is sometimes an example of vent asynchrony, depending on where you see it. But what you see is this, do you see where the orange arrows are? There's a negative deflection that you can see there before the breath happens. That means that the patient's having to start working hard to initiate their own breath. And if you think about it, so if you have a patient who has flattened diaphragms or inverted diaphragms, then the amount of pressure that they have to overcome to be able to get a breath in, because remember, the only way our vents sense, unless we're using NAVA, that a patient needs a breath is for them to generate some inspiratory flow. And either you sense that at the ventilator, or you sense it near the baby. So they have to generate some amount of inspiratory flow for the ventilator to sense that they need a breath. So you can see this is the amount of pressure that the patient has to overcome to be able to get those breaths on their own, these brown breaths, which I actually used to call gray, but some people call brown and someone else called orange. So whatever you say, I mean, the blue ones are the vent breaths. The brown ones are brown, gray, brown, orange, blue, gray are the patient breaths. So this kind of brings me on to tracheomalacia and these patients in bronchomalacia. And it's something that we see pretty commonly in our patients to some degree. Some are worse than others. And it's one of the things that contributes to us sometimes needing higher PEEP. Because if you think about it, if you remember, above the level of the glottis, you will have inspiratory flow obstruction at the level of the glottis and at your vocal cords, you have biphasic obstruction. And then below that, it's all expiratory obstruction. And so in these patients who have BPD, often, well, some of them don't have tracheo and bronchomalacia, and it amazes me whenever they get a bronchoscopy and they don't see it. But a lot of them do have some degree of it. And it actually depends on where you see, when you see them. If they're asleep and anesthetized, you may not be able to see tracheo and bronchomalacia. If they're awake and actively breathing, it's something that's easier to see. The preterm trachea is compliant, and it's actually easy to deform when exposed to positive pressure for brief periods of time. And that degree of deformation increases with the increasing time receiving positive pressure. And if you think about it, I would theorize that if you have inadequate ventilation and you're not having good air delivery to your air spaces, then a lot of it gets trapped to your proximal airways. And so there may be some stretching there. So could we avoid the cycle by more appropriately matching needs? I don't know. I think there's probably much more factors that go into this than that, but I think it may help. And then they need to do studies on this. And the incidence may be as high as a third of our patients. I talked a little bit about this. One thing to know is that compression can happen in patients who have high intrinsic PEEPs for other reasons too. And this actually can happen in adults. So remember, your cartilaginous rings are not complete rings. They form a C shape, and then there's a membranous portion posteriorly. And if there's enough of this pressure gradient that happens in patients, you can actually have collapse of this posterior membranous portion anteriorly. So you can see collapse of these air spaces that can be called nalacia. And it may be something that you can see in other people too. So I think a lot of people stress about this. Like, we do this to, and one thing that I hear in people is that the high PEEPs that we put them on, we create problems by putting them on high PEEPs. And it may be true that to some degree we need to match the PEEP a little bit better. But I think, again, like some of the other topics we talk about, a lot of times when these patients come to BPD centers, or they are past 36 weeks, that ship is sailed. And they may just need higher PEEPs for multiple different reasons. And if you can't provide a lower PEEP in an awake state, then how can you provide developmentally appropriate care? One of the things I always think about is in patients who have hyperinflation and on an x-ray, people will continue to say, drop the PEEP. And that way we can decrease the hyperinflation. But if you have small airways disease or large airways disease or just obstruction to flow, what that does is actually may actually worsen your hyperinflation. So how do we fix it? I don't have a great answer for this, unless someone did figure out the time travel or finding a cure for and preventing prematurity. You really just sort of have to individualize PEEP and reassess periodically. And remember, these PEEP changes that we make on these patients, the changes that we see in them may happen gradually. So don't panic if you don't see a change in the hyperinflation or in the patient overnight. I think that if you can relieve obstruction acutely, then that actually, I mean, if you have malacia and then all of a sudden you go up to a PEEP of 12 from 8 and they actually look much better, then that's great. That actually is a little bit more satisfying. You can see that. And in other patients, to help unload some of the stagnant air that has been stuck in the lungs for a while, that takes a little bit of time. And so you need to be patient. And then don't try to wean it like a day after you take it up to a higher level or change it that much. Even if you take it up to 12 and you haven't seen a desired response, it doesn't mean you should go to 16 the next day. You should probably get more information first. And then remember to prevent your air trapping as much as possible. So low rates again. And when I say low rates, 20 is just a starting point for a low rate. And some of our patients, if they need 5 time constants to empty their airways and their I time is 1 second, you're talking about 12 breaths a minute or 10 breaths a minute. And so that's way different than what we do for our patients who have RDS. So other things that you can do, if you can provide bronchodilators, if there's small airway obstruction, and it may be able to keep it from worsening. I think keeping it from worsening is a really important concept. Making it better is trickier, but it can happen. So finding the optimal PEEP, there's no perfect solution. So there's different things that you can do to titrate your PEEP, and then we try to do this a little bit more objectively. The flexible bronchoscopy, so we've done these at these centers here to look at large airways disease and see if we can have we do a PEEP titration with that, but that doesn't get anywhere close to small airways disease, and it may fix a large airway collapse. But there's also air leak or auto PEEP that can happen with the bronchoscope, and so it's not perfect. And sometimes you still need sedation for these patients so they can tolerate the procedures. Usually we do them when they are awake, though, which is different. So this is a bedside bronchoscopy or one that's done in the OR, depending on the center that you're at, but without sedation. So patients are mostly awake. And so doing this to somebody, they have to be intubated or have a tracheostomy. So that's the best way for us to get that information. There's esophageal manometry, where you put a balloon and you can measure pressures across the lungs. That can be done while awake, but it's difficult to trust the results in a tachypnic or agitated baby. And you have to do a breath hold for this. And so some patients really freak out for this. So they may need to be pretty calm. And then other places use things like a PEEP grid, an MRI, or a CT to look at airway collapse too. And then imaging studies sometimes have to be done in quiet breathing. And it's hard to take a patient down in more acute phase of BPD. And by acute, I still mean chronic, but like the ones who are still on sedatives and maybe have difficulty moving. And so that's harder to have them lay down in an MRI for a long period of time. Unless, of course, you have the luxury of having an MRI in your unit, I guess, near the place where a baby is, but we don't have that here. Maybe next year. So you have to pay attention to the ventilator and the baby. I said pay attention to the vent, but I also should add in you should pay attention to the baby too. It's maybe a moving target, but needs to become less dynamic over time. And I think something that you should take away from this lecture is that patients who have BPD have very dynamic needs based on the states that they are in. And those states vary a lot more the older patients get. Remember, because they're trying to do more baby things. So they're not incubating anymore. And so patients may look great while they're asleep, but they may look awful when they're awake. And we actually have to support them through both states. So look and see if their loops are closing, and then how does the baby sound? It's really important. So I'm going to go on to my frequently asked question. What vent mode is best for my patient? And I think whatever, I have my own opinion. But I think that centers do it differently, and we don't have a lot of differences in our outcomes. In general, as far as different modes, there's an assist mode, and then there's SIMV, where just some of the breaths are supported with either pressure control or volume targeted, and then the other ones are through pressure support. Assist is a tricky mode to use in a patient that can trigger the vent and is awake, because they may be fast through different states if they're really mad, and they can breath stack. And so in general, we often recommend switching to an SIMV mode for them so they can have some smaller breaths in between. Ideally, it would be nice to have some kind of crossover with NAVA, except for BPD. So some of those breaths are given whenever they want it, but we need to actually control the I time and the expiratory time too. Volume targeted ventilation is a nice concept for these patients theoretically, so it can actually account for dynamic needs. So sometimes you'll see these patients and their PIPs or their total pressures that they need for breath delivery may be in the 20s when they're asleep. And you're like shaking, you're really excited. Everybody's congratulating themselves on having a baby look better, but they may be in the 40s or 50s when they're awake. And so if you, depending on where your Pmax is, you may be able to support them better and account for that awake versus asleep without over distending or underventilating. But this only works on, some ventilators are better than others and are sensitive to manage this. We have different ventilators that we use in our unit. And so they, depending on the sensitivity, it may, or the size restrictions that you may have for providing this on your ventilators in your unit, it may be tricky to do a volume mode. So some vents actually require weights to be up near 5 kilos to be able to program in a volume that is, you know, typical for what we would give our patients. And some of them are less sensitive. And so it may be tricky to actually know that the volume that you're programming in is what you're giving. And also, if you have a huge leak, around the endotracheal tube or the tracheostomy, the vent will be alarming constantly and there will be alarm fatigue. And so that's hard to be able to provide volume ventilation if the vents, and sometimes I'll see the patients who have a big leak that we're still giving volume that either their chest isn't moving very much or their chest is moving a huge amount. And so it's probably not that reliable. So in a pressure mode, pressure control, pressure support, or it may be more effective if there's large leaks in the system. But maybe giving those big breaths that we feel uncomfortable giving, but the patient may actually need because we aren't paying attention to our tightly set volume parameters may actually be what they want. It's hard to say. So when should we adjust our vent settings? This actually, I mean, this comes up every BPD meeting, I think, is when should you make these changes on a patient? And some people say 32 weeks or 31 weeks, or I think that it's a moving target and it doesn't just like a patient doesn't wake up at 36 weeks and say, today I have BPD. We shouldn't say, oh, today we should switch you from 4 mLs per kilo to 15. You know, I think that there's probably a moving target, and that dead space actually starts increasing a couple weeks after birth. So it may be that you have to start inching up your tidal volumes to ventilate through that dead space earlier. And if what you're doing for your baby isn't working, then it's time to readjust. And they can have x-rays suggestive of severe BPD and heterogeneous lungs by 1 month of age. And so those patients are really not going to be ventilating the majority of their lungs if you're giving those tiny tidal volumes. And they may need higher oxygen and PEEP and sedation very early on when they're getting their standard vent support. They may have roving atelectasis and significantly hyperinflated areas when on high frequency ventilation. Just a caution for this is something that I see very commonly when these patients who have really obstructive lung disease from early on and they keep getting put on high frequency ventilation, even with the jet and the passive exhalation that happens on the longer expiratory times, sometimes they just cannot breathe out well. And so they can get some areas that hyperinflate. And sometimes the one lung looks huge and the other lung looks completely tiny. And then we worry, oh, maybe the other lung isn't growing, but it may just be they need to switch to conventional ventilation because whatever obstructive lung disease they have, and maybe the secretions too, may not be allowing for us to fit the needs that they have. And then early hyperinflation on x-rays. And not just hyperinflation after you've changed something on the vent, but more of a static hyperinflation. So I thought this is a really nice article that came out by Kessler in 2018 that talks about how one size doesn't fit all with tidal volume ventilation or volume targeted ventilation. And you don't have to read all of this, but I think one of the initial tidal volumes, it changes for patients with evolving BPD that are 3 weeks old, that is closer to that 5.5 to 6.5 mLs per kilo. And it probably just goes up from there, depending on the severity of their lung disease. And then in this established severe BPD, you can see down at the bottom, it's rare for us to have patients who have a tidal volume where their needs are being met with 7 mLs per kilo, especially if we need them to have a low respiratory rate, because then their minute ventilation is not going to be adequate for gas exchange to happen. All right, another important thing to talk about, I know this is beyond the concept of vent management, but this is something that happens, this is a question that I get asked all the time. And it's a really busy slide. So the question is when to trach a patient with BPD who's on the vent and we can't wean. And I think a better question is when to start discussing tracheostomy, because most of us know earlier on than we start discussing with families who's at high risk for needing a trach. And honestly, I might be extreme, but if I go to a 23-week or a 23-week prenatal consult or 24 weeks or someone that's growth restricted, I mention it. I say some patients actually need to go home on oxygen, and some of them actually need a ventilator for years, the first years after birth. And every baby's a little bit different. It is rare, but it happens. And the earlier they're born, the more commonly it can happen. But it's rare for patients if they are on a significant amount of support, and it's not just being intubated for other disease processes that are happening, for extubations to happen in most centers, I think, and the patient to thrive if they're needing higher settings after 40 weeks, at least not unless they're parked on significant non-invasive support for a long period of time. Now, there's a paper that shows that there's a lot of intercenter and intracenter variability on the timing of tracheostomy. And I think in general, the age at trach may be changing and becoming later in some centers. We are a late trach center where our average age is 49 weeks. And that's for a lot of different reasons. But we can prescribe this, but I think you have to remember that there's a lot of problems. We don't solve the disease process. We create a stable airway. We don't make the lungs better necessarily by putting in a tracheostomy. They're still going to be connected to the ventilator. And that actually may be a pathway to home, but it's just the first step. And sometimes it takes months for them to be able to get on a portable home ventilator. And there's no evidence, there's still a really high risk of having mortality at home. There's trach accidents that happen, and there's a lot of different morbidities and readmissions that happen in these patients. It's very hard to transport a patient with any kind of technology dependence, but especially with a trach event. And we think that neurodevelopment is going to be better because they can actually tolerate therapies and move around more because they now have a stable airway. But we have no high quality evidence to prove it, except for one study that suggests patients who are trach before 120 days may have better neurodevelopmental outcomes. But what we know is that intensive therapy is actually really important for these patients who are at high risk for neurodevelopmental impairments. And if they can't get any of that on invasive or non-invasive support, then it makes sense to proceed with trach. Remember though, once we send these patients home, these parents end up providing 24-hour coverage a lot of times, and home nursing is very shorthanded, and a lot of states actually don't pay well for nurses to come out to the houses, or people call off. And so parents being able to work, take care of other siblings, and do all that stuff is very difficult. Like I said, timing of tracheostomy is really variable. It can be as low as 42 weeks. Some places are as high as 51 weeks. May actually be as high as 54 weeks based on current info from centers that do trachs later. One reason that we do trachs a little bit later, because I think if someone comes in from the outside or they get these patients later, they're like, why are you waiting so long to put in a tracheostomy in these patients? And then there's several reasons. One is that a lot of patients with severe BPD are only 2 kilos at 36 weeks, and some places have size restrictions. Usually our ENT people usually like them to be at least 3 kilos before we put in a tracheostomy. Some of them get transferred to us at later gestational age and do not have a tracheostomy. And then they also need to be stable. And so if they have a really high FiO2, or you can't even move them from the room, then it's very hard for them to go down to the OR or not be a fire risk, because they actually have to be disconnected from the ventilator for a short period of time for them to have the tracheostomy. And surgeons probably wouldn't like it very much if their patient has a high risk of dying in the OR to put in a tracheostomy, unless we think that there's a critical airway and it's an emergency situation. One of the things that I see is that parents aren't ready. They want to wait longer to see if extubation trials can happen. And I think it's hard for us to say no sometimes. I am the no sayer in my family, and actually oftentimes here too. And it's a bummer to be the one that bring that to them. But I think something to remember is that tracheostomy is not a failure. The baby didn't fail, the parents didn't fail, and we didn't fail them. A tracheostomy provides a stable airway by putting in a tracheostomy tube and giving these patients a tool that is necessary for them to thrive. And I think that's something that we don't represent very well when we talk to these families. And no, it is not smooth sailing. And we don't say like, this cures everything and everything will be great whenever you go home. It is not. It's really still a rough road. But if we want these patients to thrive, then tracheostomy is important for them. And if they need longer-term ventilator support to interact and receive input from the world around them, then a stable airway is best. So be careful when you talk to families about trach. I think earlier is better. I know it's scary, and we think that parents may not be able to handle that information, but it doesn't mean that we should withhold information from a family. In order for parents to make a decision that's right for them, they need to have all the information available. Okay, I am going to talk a little bit about hyperinflation. I think I'm okay on time. Do I have another 5 minutes or 5 minutes for questions? Is that standard? Okay. So the perils of hyperinflation and ventilator asynchrony. So like I said before, our conventional ventilators, and remember, this excludes NAVA. And NAVA is a whole other topic. They're flow driven. So a patient should initiate a breath for a ventilator to deliver the rest of the breath. Your diaphragm contraction is the main driver of inspiratory airflow. So if you look at this is, I am sure that most of you, if you haven't seen this, if you're early in training, you will see it because these patients are surviving more and more. And you will see these flattened diaphragms. These are inverted, actually. And then the heart looks like it's sort of floating. We call that the floating heart sign on our team. And there's a trach sign too. So you know this patient has chronic lung disease too. The diaphragm contraction is the main driver of inspiratory airflow. And it would not be easy for this diaphragm to contract at all, right? And in fact, actually, if it were to contract, because it's inverted, if it goes up, then it may actually be expiratory airflow that goes in, pardon me, instead of the inspiratory airflow that a patient wants to get a breath. So this creates patient ventilator asynchrony. And you don't necessarily need to have this to see this happen, but I do see a correlation between hyperinflation and vent asynchrony. And this can be, and one of the biggest things that makes me think about this is in patients with severe BPD, not only if they have hyperinflation, but what you'll see is that they look okay when they're sleeping, but they are super agitated when they're awake. And sometimes it's just adjusting the vent support to what they need. But other times you may go in the room and see a patient awake and retracting and working, and the ventilator is at a rate of 15 or 20 or whatever you set in there. But that's not what the patient is breathing on the monitor. Or if you put your hand on their chest, you may feel the chest trying to move, but the patient's actually not getting the breath delivered to them on the vent. So in our center, we did a retrospective review of infants with severe BPD who received a tracheostomy, and 11 of these patients died. 8 out of the 11 who died had hyperinflation on the x-ray at the timing of tracheostomy, and these patients took a lot longer to convert to a home or portable ventilator. So I challenge you all to look for ventilator asynchrony in a patient who just can't come off sedation or who just keeps getting agitated when they're awake or is extra sensitive to changes. Look for that. Look at the vent. See if there's anything that you can adjust to help them have better air emptying or air trapping. See if you can alleviate some of the airway collapse that happens. And then maybe bronchodilators can help. That's one of the most unsatisfying things, I think. Bronchodilators may help, but it may not be a profound help, and it may be hard to see it unless you've been treating them regularly for some period of time. But if you're giving it, you may not just want to say, I'm going to give this and then walk away. You should see how they look afterward, but you should see how they look after a couple of treatments too. So, and there may not be a solution, especially going back to that slide before, that there's poor stromal support and their elasticity is not great. It may just be that time and development of alveoli is what needs to happen. All right, so I'm going to quickly go over this. I mean, we've talked about most of this. Blood gases and x-rays are often unhelpful in these patients to define stability. And because they are older, we actually have to get input from a lot of other people. Like I said, our 5 to 10 minute assessment in the room is not sufficient. So we need multiple disciplines to work with these patients and get their input and not all be working in parallel, but have connections with each other to define stability in these patients and success. Not just stability, I guess. Stability means that they're doing okay, but we want them to thrive. And so we want to move from subjective to objective assessments. And this is a nice slide from Nationwide that talks about these 4 phases of severe BPD. We really want them all to get this phase 4, where they're actually doing well and they're prepping for discharge. And this is, you guys can read all this in these, this presentation will be available to you afterward, but you need multidisciplinary input. So are they able to participate in therapies? Are they withdrawing, or is it air hunger because of dynamic needs in different states? How is their growth? Is their length increasing? How has their overall state been? And you can see beside these, this is who the people are that should be giving us input. Do they have evidence of pulmonary hypertension? Is it improving, stable, or worsening? And how do they sound in that exam that we give? That is the shortest exam. If all those things are going well, then maybe you can consider decreasing support for them and see that they're thriving. If they're not, then it may be time to adjust or wait. This is this BSRI that's becoming a little bit more widespread. And this looks at development over time, acquiring developmental milestones, but also when the therapists work with them, looking at their respiratory stability. And one bad score doesn't necessarily mean that we're failing. It may just be that they're really angry at the timing of it, but trending it over time is helpful to look and see if they're doing well, especially if you're accounting it for other things too, like how are they growing and how is their echo looking and other things. So if I can give you three conclusions. Definition of BPD has changed in the patient as the patient population has changed, but there's a lot of overlap. Evaluating evidence is tricky. And then vent management differs significantly in these patients and is almost opposite for RDS. And you actually have to be patient. I didn't put that on there, but you really have to be patient and changes happen really slowly. So, your questions? There are two in the chat.
Yeah, thank you so much, Dr. Lagosky. That was an excellent review on vent strategies. I do have two questions here in the chat, and one is looking at the respiratory loop helpful in determining the level of PEEP needed in patients with BPD, particularly looking at the expiratory limb of the lung?
Yeah, so that's a great, I wanted to put in a picture of the respiratory loops because you really would like those loops to close in the patients. Sometimes it's hard to get a good loop while they're awake though, unless they're in a calm alert state. Sometimes it looks like you're trying to use an Etch-a-Sketch and your hands are going crazy. But having a loop close really helps. And then seeing that takeoff that happens at the critical opening pressure. So a loop on the bottom should not be flat for a long period of time. It should start to curve upward. This doesn't really help you that much. It shows that I'm playing with my ponytail holder that I have on my wrist, but it should have like an upward curve and not be flat and then up here. So yes, you should see that should help you look at your PEEP and help optimize it. But sometimes it's hard it may be flat to a PEEP of 20 if you're super hyperinflated. So it may help you sometimes, but it may not help you a lot, especially in those patients who are already in extremis.
Perfect, thank you. And then the second question is about, can you comment on the risk of tachyphylaxis with chronic scheduled bronchodilator use in severe BPD?
No. I don't, I wouldn't be qualified to talk about that. And I don't actually, we don't use bronchodilators that much. We don't do continuous bronchodilators unless we have a patient who looks like they're close to death. We use more commonly, we will use long-acting beta agonists sometimes if they have a really favorable response. But I've never experienced that in a patient, but I've also not put them on continuous albuterol. I can count probably on one hand the amount of times that I've put somebody on continuous albuterol. So I guess that probably doesn't answer your question at all. So no, I go back to answering that and that I cannot.
Perfect. And then someone also asked, how do you determine the appropriate I to E ratio?
So it should be at least, well, ideally it'd be 1 to 5. It's really hard to achieve that in a patient who's spontaneously breathing because everyone breathes above a set rate of 12 unless they're passed out. But ideally in between the breaths that we're delivering, sometimes depending on the I time, 1 to 5 is great. And for patients with the most obstructive lung disease, that is ideal. Above 1 to 3 is really important, I think, and a little bit easier to achieve. And it really depends, so not everybody's severely obstructed. Some of them have more parenchymal disease, and you may not need that 1 to 5, but at 1 to 5 is supposed to be magic.
Perfect, thank you. And then there's a question about when do you recommend if babies are on large tidal volume, which is a BPD setting, but they remain tachypneic? So what should be the approach then?
Some babies are tachypnic and they're okay. Some babies are tachypnic and they are not doing well. I think that the tachypnea may also reflect state, and it may just be that some babies breathe faster. But if they have more heterogeneous lungs, you do need to have bigger breaths sometimes. And if you start to treat the tachypnea and you keep going up on your rate, and you have to give the higher I times, then you really risk breath stacking. And so sometimes we just have to give small pressure support breaths in between to help provide that comfort, but allow for adequate emptying in those slow, empty compartments.
Thank you. Those are all the questions in the chat box. If you have any additional questions, please unmute yourself and ask them now. And for the feedback for this session, please email Dr. O'Reilly. There is an email in the chat box for that too.